Hello everybody. I'm very pleased to welcome you to this official press conference of IAS 2019 on integration of HIV and sexual and reproductive health. I'm Lucy Stackpool-Moore, the Director of HIV Programs and Advocacy with the International AIDS Society. I would also like to add a special welcome to those of you who are joining us online. This session is being live streamed and a recording will also be posted on the conference website. In a moment, we will hear brief remarks from our panellists and then we'll be very glad to take your questions. The embargo on the abstracts presented at this press conference is now lifted. Too often we discuss HIV in isolation from other health and life concerns like sexuality, intimacy, preventing unintended pregnancy, sexually transmitted infections, and other infections like tuberculosis. This siloed approach has specific consequences for everyone, and especially for women and girls. Women and girls need appropriate, accessible, affordable, and a variety of services to best protect their health and rights, including access to integrated, quality, and comprehensive sexual and reproductive services. And this includes HIV education, prevention, and treatment. It also includes other areas which we're going to hear about in the panel today. They should be able to access effective and non-stigmatizing contraceptive counseling, STI and TB screening, and HIV care all in one place. Just weeks ago, the Evidence for Contraceptive Options and HIV Outcomes trial, known as ECHO, added important evidence to address long-standing concerns that certain hormonal contraceptives might increase a woman's risk of contracting HIV. We're here today to discuss integration with new analysis from the ECHO trial, as well as from a study from Latin America on HIV and TB. Please note that in addition to the ECHO analysis presented here today, an additional study compared pregnancy rates among women in the trial, and that abstract is also available for those interested at this conference. Another area of important consideration in terms of integration and also in terms of quality services was just published this morning in the Journal of the International AIDS Society, organised by the WHO, a special issue focused on partner notification. Partner notification is the voluntary offer of testing to sexual or drug-injecting partners of people living with HIV. The provision of partner notification since 2016 has been a WHO minimum standard of care for both newly diagnosed individuals as well as those on treatment. Findings from the studies and experiences presented in the Journal of the International AIDS Society today, the special issue, indicate that implementing partner notification services is a feasible and effective approach for assisting people with HIV to get their partners tested for HIV. And there's going to be a session about that tomorrow evening with details about that are in the program. Now on to our discussion. Our first speaker is Nelly Mugo, Chief Research Officer with the Kenya Medical Research Institute and Associate Professor at the University of Washington. Nelly will provide an overview of the ECHO trial findings to set the stage for the further discussion. Nelly, please go ahead.
Thank you. Good morning. I'd like to start by thanking the conference organizers for this opportunity to present a summary of the ECHO trial results alongside with my colleagues who worked on the ECHO trial. The ECHO trial results were initially presented on June 13th at the South African AIDS Conference and simultaneously published on The Lancet. So you can get that publication and get the full details. ECHO stands for the evaluation of contraceptive options and HIV outcomes. And the ECHO trial is designed to answer the question of whether the use of DMPA intramuscular copper intrauterine device and the levonorgestrel implant increase the risk of HIV infection. We all recognize that safe, effective contraception is essential to the health and development of women, children, and communities worldwide. We always say the well-being of women is the well-being of everybody. The women in the African region, as we know, carry a very high burden of HIV infection. And in geographic locations with high HIV prevalence, there's a predominance of use of the DMPA intramuscular injection as a contraceptive option. The question of whether use of hormonal contraception increases HIV risk is about 3 decades old. And as the HIV epidemic took hold in many countries, there are a number of observational studies that suggested a possible increased risk of HIV acquisition for women using progesterone injectables, particularly the DMPA-IM. Because of the limitation in the design of these studies, mostly observational, it was not possible to determine whether the observations of HIV infection were due to the type of contraceptive method or there were other behavioral factors or that involved the selection of method by women. So the results of the ECHO trial are currently the most robust to date that can give us, that can address these concerns. The ECHO study was conducted in 4 African countries in settings of high HIV prevalence. That's Eswatini, my country, Kenya, South Africa, and Zambia. So how was ECHO designed? ECHO was a multi-center, open-label, randomized clinical trial which compared HIV incidence amongst women who were randomized to the intramuscularly delivered depomedroxyprogesterone acetate, which is DMPIM, a copper intrauterine device, the IUD as it's commonly known, and a levonorgestrel implant. And we also compared by randomization arm, rates of pregnancy, method continuation by method, and any adverse or harmful effects that led women to discontinue their method of use. The trial began in December 2015, and participant follow-up ended last year, October 2018. So who was enrolled and randomized on the ECHO trial? We enrolled 7,829 women ages 16 to 35 who were seeking contraceptive. The average age of the women enrolled in ECHO was 23 years. 7% reported more than one partner in the last 3 months prior to enrollment, and 50% reported using a condom at their last sexual contact. One of the things that was good outcome out of the implementation of ECHO is that more than 90% of women stayed on their randomization method. And they also stayed through our study follow-up, which was up to 18 months. So what did the ECHO trial tell us? Sadly, HIV incidence was unacceptably high. In total, we had 397 of the 7,829 women acquiring HIV during study follow-up. This gave an overall HIV incidence rate of 3.8% per year. There were 143 infections amongst the DMPA-IM users, 138 amongst the copper IUD users, 116 amongst the levonorgestrel implant users. This was in the context of an antiretroviral program rollout, treatment rollout, and we provide a standard of care for HIV prevention, which Dr. Ivana will speak more to during her presentation today. One of the key findings was that the HIV incidence rate was not significantly different by method of contraceptive, which was one of our primary questions. All 3 methods were found to be highly effective and safe for prevention of pregnancy, and pregnancy rates were approximately 1% per year. And our colleague, Dr. Marisiana Onono, will be making a presentation on pregnancy outcome this afternoon at 2:30 p.m. I encourage you to attend that session. STI rates were high, and my colleague here, Deese, will speak to that. In conclusion, this well-executed randomized trial did not find a substantial difference in HIV risk among the methods that were evaluated. All the methods, all the contraceptive methods, were safe and highly effective for HIV prevention. So though this result is reassuring, it's truly not time for complacency. And this was stated again at the AVAC session yesterday. And I think that it's important to note that we need to call for urgent action. There's an urgent need to respond to the high rates of incident HIV infections amongst adolescent girls and young women seeking contraceptive services in geographic locations with high HIV incidence. Our services must be woman-centered, and they must meet the needs of women. When women enrolled in ECHO were offered all 3 contraceptive options, there's a very high rate of acceptance and method continuation. Therefore, we have a responsibility to close the gap of unmet need for contraception in the African continent by providing access to high quality and a wider range of contraceptive services. I just want to say, as a provider in Africa, as a scientist, that I feel strongly we have failed young women who come to us seeking reproductive health services or contraceptive, but not providing HIV prevention services as a combined standard of care package. There's been a lot of discussion about integration of HIV and family planning, but the implementation hasn't happened to a level where it has impact in women's lives. To be on the right side of history, as was stated in yesterday's AVAC session, we must act urgently. And I think this is a global responsibility. We need resource allocation for this to be a reality. We need to have the funders, policymakers, advocacy groups, the media, service providers, and scientists act urgently to make a difference so that we do not see this rate of HIV infections amongst young women. Thank you.
Great. Thank you very much, Nelly. And I think your concluding remarks there really highlight the importance not only of the access and availability of those services, but the quality of those services to meet where women are and young girls in their lives. So thank you very much. Our next speaker is Thesla Palanee-Phillips, Network Trials Director at the Wits Reproductive Health and HIV Institute in Johannesburg, South Africa. She will discuss data from the ECHO trial that found high rates of HIV among young women in South Africa. Thesla, please go ahead.
Thank you very much. Good afternoon, everyone. I'd like to start by thanking the conference organizers for inviting us to the session. And as was mentioned, I'll be speaking to you specifically around the HIV incidence data at the South African sites. So, I think coming from South Africa as a South African woman and being a trial leader in South Africa, I was very excited when we started the ECHO trial, because I had hoped that we would see some shifts in HIV incidence. But the data that I'm going to share with you will tell a different story. As you all know, South Africa is globally known for having the highest rates of HIV incidence and prevalence globally. And the difficulty is that 1 in 5 people in the cities that we live in South Africa are infected or affected by HIV. These are predominantly young women that are not able to negotiate condoms, are in socially, economically compromised situations, are not really able to have much of a say when it comes to sexual reproductive health. A few years ago, we released the HSRC data, the Human Sciences Research Council data, which gave us an indication that the incidence amongst women in South Africa 15 to 49 had dropped from a level of 2.28% down to about 0.93%. This left us feeling really hopeful. All the efforts for test and treat, initiating people on antiretroviral therapy, and the expansion of PrEP rollout to our key populations seemed to have been working. However, when we did the ECHO trial, as I said, we had a different story play out. So as Nelly mentioned, ECHO was conducted across 4 trial countries with 12 sites, but the data that I'll speak to is specific to South Africa and the 9 sites across our provinces. Young women were enrolled, as we said, 16 to 35 across all the sites, but the data for South Africa is specific to 18 to 35-year-olds. The women that were enrolled were young. Majority of them were, the median age was 23 years, and the majority of our participants at 63% were less than or equal to 24 years of age. The incidence data for the trial has been discussed overall, but we had in South Africa 345 of those infections. So a major proportion of the infections came from our country. This gave us an incidence rate overall of 4.51%, which is much higher than the general overall ECHO percentage. Incidence at every single trial site in South Africa was greater than 3%. Now, this is staggering when you think about the number of people in this room. If there were 100 of us, 3 of you would have HIV. In some of our trial sites, this went up to 7%. And when you're conveying information like this, it's incredibly difficult. I think prospective studies give us good indication of exactly what's going on with incidence, and ECHO is a gold standard trial that allowed us that opportunity, obviously comforted by all of the services that we provide. Exploring risks among these women that became HIV positive was incredibly important, and there were a few factors that stood out. Women that were young, less than 24 years of age, had baseline infections of STIs, specifically HSV2, gonorrhea, and chlamydia, were at higher risk of getting HIV infection. So these were baseline reports, and so that was a predictor of risk at the end of the trial. Clearly, much needs to be done in terms of risk reduction amongst our populations to start to have us to see a shift in this high prevalence. Our take-home message, South Africa and our other African countries, women are still at extremely high risk of HIV infection. We need more integration in terms of PrEP delivery, prevention options for men and women, so that we can see a collective reduction in risk amongst all of our young people that are sexually active. To echo all of Nelly's support, I think it's really, really important that more resources are channeled into future work amongst this population that are not able to negotiate options for themselves. Thank you.
Great. Thank you very much, Thesla. And I think your point really about the age of the participants in ECHO raises some really important considerations for services for young women, as well as the other issues you raised there. Thank you very much. Our next speaker is Jen Deese, an epidemiologist at FHI 360. She will discuss sexually transmitted infection risk among the ECHO trial participants. Jen, please go ahead.
Thank you. Good afternoon. So as the chair shared, I'm going to share with you about the results of a secondary analysis that we did in the context of the ECHO trial on sexually transmitted infections among women who were at clearly high risk of HIV. But first, I would like to thank the conference organizers to present and share these results from these secondary analyses from ECHO. And I would also like to acknowledge my co-authors, the ECHO Consortium, many of whom are represented here, and the trial funders. So we know that limited data are available on the risk of sexually transmitted infections in association with the use of modern contraceptive methods. And the results I will share with you today, and which are presented in a poster session tomorrow, are the first data on this question from a randomized clinical trial. So the ECHO trial provided a very unique opportunity to evaluate the risk of sexually transmitted infections. In this analysis, I'm speaking specifically to chlamydia and gonorrhea, among women randomized to DMPA-IM, Depo-Provera, a levonorgestrel implant, and the copper intrauterine device. The women returned for scheduled visits every 3 months for up to 18 months, and this allowed us to accurately record contraceptive start and stop dates and enabled us to better assess the relationship between contraceptive use and STI risk than had been possible in 20 years of observational studies. In this analysis, we evaluated baseline and final visit prevalence of chlamydia trachomatis and Neisseria gonorrhea by nucleic acid amplification testing. And we also evaluated the association of these sexually transmitted infections with randomized contraceptive method. At all visits in the ECHO trial, women were screened and treated as appropriate in accordance with national guidelines for syndromic management. In addition, at their first and last visits, we conducted nucleic acid amplification testing for both chlamydia and gonorrhea. So we had baseline and inline etiologic results for those pathogens. Women with positive results at baseline who were not syndromically identified as infected at screening were called back and treated by the time of enrollment. And throughout the trial, women were invited to bring their partners both for testing and treatment, but unfortunately, partner uptake at all of the sites, although we don't have data recorded in the database, we know anecdotally in our discussions that partner uptake of services was sadly incredibly low. Overall, we found that women seeking family planning in these settings have high prevalences of both chlamydia and gonorrhea. The overall chlamydia prevalence was 18% at baseline and 15% at the final visit, keeping in mind this was following NAT testing at baseline and appropriate treatment. The overall gonorrhea prevalence was almost 5% at both baseline and the final visit. Prevalence for these sexually transmitted infections, mirroring what we see with HIV, were highest in South Africa and Eswatini, intermediate in Zambia, and lower in Kenya. Moreover, as the other speakers have referred to, younger women were at higher risk. So at both the baseline and the final visit, we saw much higher prevalences of both chlamydia and gonorrhea infection among women aged 16 to 24 as compared to their older counterparts who were 25 years of age or older. Moving on to our analysis of STI prevalence associated with the contraceptive methods. At the final visit, we found that DMPA-IM users had a 30% lower risk, which might surprise some of you, of gonorrhea infection as compared to users of the copper intrauterine device. We also found that DMPA-IM users had 20% lower risk of chlamydia infection compared to users of the levonorgestrel implant. And these results were statistically significant in two different types of analyses, one which we commonly refer to ITT, intention to treat, or as randomized, and the results were the same in a consistent use analysis. These results demonstrate that women seeking contraception in the trial settings have very high STI burden. The high prevalence rates at the final visit, which were approximately comparable to the baseline prevalence rates, even despite baseline treatment, demonstrate that syndromic management, which the trial employed during follow-up, is inadequate for STI prevention and treatment in this population. Chlamydia and gonorrhea are associated with multiple adverse reproductive health outcomes for women and are important drivers, along with other sexually transmitted infections, of the HIV epidemic. Syndromic management is the predominant approach for STI detection and treatment in the countries in which the trial was conducted. However, among women who have cervical, gonorrhea, and chlamydia infections, the majority of them are asymptomatic. And among asymptomatic women, syndromic management has very low sensitivity, low specificity, and a low ability to correctly identify the pathogen that can be used for appropriate treatment consideration. Our take-home message is that routine screening, especially among young women and among women who are choosing to use intrauterine devices for contraceptives, novel point-of-care diagnostic tests, and models for expedited treatment, for which there have been several good papers recently, should be considered in these areas of high STI burden and maybe yet another important tool in the fight against HIV. And additional more detailed data from this analysis will be presented in a poster session tomorrow from 12:30 to 2:30 in abstract LBPE-B16. Thank you.
Okay, thank you, Jen. Our next speaker is Ivana Beesham, a physician with the Match Research Unit at the University of Witwatersrand in Durban, South Africa. She will share analysis of PrEP uptake among women in the ECHO trial. Ivana, please go ahead.
I would like to start by thanking the IAS press conference for inviting me to participate and discuss my poster, which is entitled Integrating Oral PrEP into a Large HIV-Driven Endpoint Clinical Trial in Eastern and Southern Africa, the ECHO Trial Experience. Pre-exposure prophylaxis, or PrEP, taken as a daily oral pill, has been proven to be effective in reducing the risk of acquiring HIV. The ECHO trial, which began in December 2015, was an open-label, randomized clinical trial that assessed 3 different contraceptives and their relationship to HIV acquisition. The trial was conducted at 12 sites in 4 African countries. All participants had received a comprehensive HIV prevention package, which included risk reduction counseling, testing for HIV, testing and treating STIs, offering male and female condoms, and partner HIV counseling and testing. Now, during the course of ECHO, country policies and guidelines had evolved to increase access to PrEP. The ECHO protocol had explicitly permitted PrEP use, and PrEP first became available in ECHO in Kenya in May 2017 with that country's national rollout of PrEP. Demonstration projects of PrEP began in 2017 near the sites in Eswatini and Zambia, as well as near some South African sites. A major event was the consultation that was held by the South African Medical Research Council in November 2017 that recommended that PrEP be provided in HIV prevention trials as standard of care. This guidance opened the door for ECHO to provide PrEP on site at the South African sites, which began in March 2018. We found that of the 7,829 women that were followed in the ECHO study, just under 50% were still in follow-up when PrEP became available, and 622 women, or 17.2% of that subgroup, had initiated PrEP. Women who initiated PrEP were slightly older, more likely to be unmarried, not living with their partner, having more than one sexual partner, and had higher rates of chlamydia trachomatis. They were also less likely to be earning their own income and receiving financial support from partners than those who did not initiate PrEP. There was no significant difference in the uptake of PrEP by randomized contraceptive group. We found that there were 37 seroconversions among women who had access to PrEP but did not initiate PrEP, and only 2 seroconversions among women who initiated PrEP. Of these 2 women, 1 woman had stopped PrEP approximately 2 months prior to seroconversion. So in conclusion, the provision of PrEP as part of HIV prevention standard of care in the ECHO trial was feasible, and other clinical trials with incident HIV as a primary study outcome can and should plan to offer oral PrEP to persons who desire PrEP as part of comprehensive HIV prevention. My final words to you. Sometimes you need to take a bold step and offer the gold standard, PrEP. Do it soon. Don't take a while. Do it in an HIV prevention trial. In ECHO, HIV incidence was high, something we just cannot deny. We must provide state-of-the-art HIV prevention integrated with quality contraception. Women should be able to choose which HIV prevention options they want to use. My dear media friends, write it, record it, put it in your file. PrEP can be integrated in an HIV prevention trial. Thank you.
Well said, Ivana. Who said scientists can't be activists as well? Thank you very much. Our next presenter is Serena Koenig, a physician at Brigham and Women's Hospital and also works in Haiti. She will discuss another aspect of integration, integrating HIV and TB and sharing data from Latin America. Serena, please go ahead.
Hi, so I am presenting on behalf of the CASANET network. CASANET is an NIH-funded network that involves several Latin American countries. And in particular, I'm presenting on behalf of the Jesquio Center in Port-au-Prince, Haiti. From 2006 to 2015, the WHO guidelines progressively recommended earlier antiretroviral therapy, both for patients without TB and for patients with TB. So back in 2006, we waited until patients had advanced AIDS before we started antiretroviral therapy. And for patients who had both HIV and tuberculosis, we delayed the initiation of antiretroviral therapy until they were quite stable or had completed their tuberculosis treatment. Over time, that shifted, so that by the year 2015, we were recommending very fast, universal antiretroviral therapy for patients who did not have TB, people living with HIV without TB, and for those with HIV and TB, that if you had very advanced AIDS, you would start your TB meds within 2 weeks, or you'd start TB meds and then antiretroviral therapy within 2 weeks, and everyone should be starting within 8 weeks. So a very dramatic shift in policy. So what we wanted to look at was how did that change in policy affect outcomes for patients? So our cohort included Brazil, Chile, Haiti, Honduras, Mexico, and Peru. It included ART-naive adults, and we defined baseline tuberculosis as having TB within 30 days of enrollment, 30 days diagnosed 30 days before or after. At CROI 2019, we presented data demonstrating that in Latin America, the time to antiretroviral therapy initiation dramatically decreased from 2006 to 2015. In this study, we wanted to look at what was the association between that faster ART initiation and mortality. We looked at this both in patients with HIV and in patients with HIV and TB. Patients who were diagnosed with tuberculosis were more likely to be male, living in Haiti or Peru, have a low education, older age, or lower CD4 count. So we conducted Cox proportional hazard model, and we found that patients patients who are living with HIV with or without TB across all CD4 strata, except the most advanced, have had improved survival over time. So just to restate that, for people living with HIV from 2006 to 2015, we believe that the policy of earlier ART initiation has been associated with a dramatic decrease to the time to start treatment and a dramatic increase in survival. That occurs at all CD4 strata for people who do not have tuberculosis, people living with HIV alone. Among patients with tuberculosis, their survival is a little bit lower than those who did not have tuberculosis, but across all CD4 strata, except those with a CD4 count under 100, survival has also improved. So very good news. The WHO had recommended some very thoughtful and evidence-based guidelines. The countries of Latin America took those guidelines. They implemented earlier treatments, both for patients with TB-HIV and for patients with HIV. That was translated into improved survival for patients living with HIV in Latin America.
Thank you, Serena. Some good news indeed. Our final speaker is James Kiarie, who is the coordinator of human reproductive human reproduction, reproductive health and research with the World Health Organization. He will speak to the program and policy implications of the new evidence we've heard here today. James, please go ahead.
Thank you very much, and also thanks to the organizers for inviting me to present in this panel. I think if one looks at the ECHO trial, and the investigators have really presented some of the things we see from the ECHO trial and what are the implications. I think one of their key findings is that there was no statistically significant difference in HIV acquisition between the three methods. And this was the primary question that the trial was designed to answer. And when we say statistically significant, it is that whatever difference was observed was less than 30% in terms of what the study could have found to be statistically significant. So they observed, if any difference, a smaller difference than 30%. This was, for those people in family planning, a sigh of relief because there's been a lot of concern as to whether the methods were increasing HIV infection risk. And this is why for WHO we have really been invested in this study, because we are concerned that the contraceptive methods must be safe. However, as you've heard from the presenters, the HIV incidence was high. And this was not surprising for the sites, because the sites were chosen as places which had high HIV incidence. But it has really been surprising to many of the programs and policy makers that the HIV incidence was as high as this. And this actually, I think, is a wake-up call that we really need to have conversations between those in reproductive health, in family planning services, and those in HIV prevention as to how we can do a better job of HIV prevention as we provide contraceptive services. I think another important finding was that when you look at all these three methods, and some of the methods were not commonly used in the setting where this study was done, they were all fairly well used with very good pregnancy prevention and safety. And therefore it's unacceptable that women continue to access often only one method. They do not have choice. And this really study demonstrates that if choice was provided, women can choose different methods and they're able to use them and use them effectively. I think the last presentation on the STIs is also something which is a wake-up call. STI have been forgotten. These women had prevalence, if you look at chlamydia and gonorrhea, of up to 20%, 1 in 5. And this prevalence was high at baseline, and even at the end of the study. And remember, these were women participating in a clinical trial. They were being seen every 3 months. Mm-hmm. They were being treated if they complained of symptoms. Treatment was available at no cost to them. And still, the STI prevalence was still high at the end. So I think the messages from ECHO are very clear, and has been mentioned, that we need to do something about HIV prevention in family planning services. We need to have conversations on this. We need to do something about availing and expanding the method mix that women can choose between the methods available. And we need to address the issue of STIs that are very high prevalent. This conversation, though, we need to think deeply about it, because the ECHO trial did a lot of efforts to prevent HIV infection. The women were being tested regularly. They were being, as we say, treated for STIs. They were being provided with condoms. They were being counseled. And we need to go beyond and really think, what is it that we can do that can be effective in this setting to achieve two dual outcomes? And I think we must see these as opportunities for a win for both family planning And you must provide family planning because the women come for contraceptive services. And we must be careful that we do not convert family planning services into solely HIV prevention services. So the women have dual needs, and these needs must be met together in a holistic manner. For WHO, we are now looking at the evidence and synthesizing the evidence, and on 29th to 31st of July, we'll have a guideline development group that will come up with recommendations regarding the use of contraceptive for women at high risk of HIV infection. We are also supporting the countries so that they can address some of these policy implications, particularly looking at integration of services and looking at expansion of method mix. Often, sometimes when you talk to people who have been in the programs for a long time, they feel discouraged because these have been conversations that have been going on for a long time. There is, however, hope that this time we can succeed, because I feel that even among the people who benefit from our services, they are really also getting tired from these siloed approaches where you just look at one issue and you do not provide integrated services. So I think there is going to be increasing push from the advocates and from the service providers for all of us to think more about integrated approaches.
Thank you very much, James. I think you've raised some really important concluding remarks there that really highlight what we've heard in terms of the importance of choice, the comprehensive nature of services, and also the quality of those services so that they can be effective for women and girls, as we've seen in the various presentations today. We have just a few minutes for questions now, so we'd be happy to take questions. Please, if you do have a question, line up to one of the microphones and start by indicating your name and the outlet, and we ask that you keep your questions relatively short. Thank you. Please go ahead. Yeah.
Hi, I'm Heather Berner from Medscape. I think this question is for Dr. Mugo, but any of you can feel free to answer. So you all are talking about prevention of HIV, various methods. The dolutegravir press conference we had earlier, we're talking about once women acquire HIV. I wonder if anyone could speak to what is the image then that we're putting together of what it's like to be an African woman, a South African woman, a Kenyan woman, et cetera, in terms of their experience with the healthcare system. Could anyone speak to that?
I'm trying to put it together. I think you're asking, so I think you're talking about two things. There's the issue of the prevention services for the woman seeking contraceptive, but there's still the issue of the HIV-infected woman seeking an optimal option. And if they're using dolutegravir, they still need contraceptive. So I think what you're bringing out, and we need to be reminded again and again, is that integration of services shouldn't just be in the family planning clinic for people without HIV, that women with HIV also require to have the services combined. And speaking back to what Dr. Kiarie said, siloed services really are a disservice to women. You come to the clinic, you get your ART, you move across to another space, and you line up for family planning, and the chances are something's gonna fall off. Because people's lives are not just about accessing healthcare. They access healthcare so that they can lead lives. They don't lead lives to access healthcare. So I think we need to treat the people who come for services to us. There was a presentation, I think this morning, the lady from South Africa plenary said, she said, I think it's only healthcare providers who think clinics are fun to go to. So I think we need to remember that. And maybe we need to innovate, like she mentioned this morning, about how to make services more accessible and in a holistic way, perhaps outside of the structures that we currently provide. So maybe start thinking outside the box. Okay. Thank you for your comment.
Thank you. And I see too that in the interest of time, we'll take both questions and then open up to the panel. Thanks.
Hi, I'm Christian from NAM AIDS Map. And my question is just regarding the PrEP uptake and the women who chose not to actually take the PrEP during the study and who then went on to seroconvert. And what were some of the factors associated with not taking the PrEP?
Okay, thank you. And Ivana, just before you respond, let's take the second question at the same time.
Hi, my name is Rika. I'm from the Fuller Project for International Reporting. One of the panelists mentioned that she believed we had failed young women, and we talked about in the data some of the higher prevalence rates among young women. I'm wondering if somebody could elaborate on what is driving that and what the nature of that failure is and possible solutions.
Okay, thank you. Ivana, do you want to take the first one?
Hi, yeah, that's a very good question. So just a reminder, so PrEP was offered as standard of care in the ECHO study. So a lot of data on PrEP use, reasons for discontinuation, reasons for starting and stopping PrEP were not captured as part of the ECHO trial. Having said that, PrEP was offered through two broad approaches. So in the non-South African sites, participants were referred to facilities offering PrEP either via demonstration projects or in Kenya with a national rollout. In South Africa, on the other hand, even though PrEP was available in some demonstration projects, access and availability was still very limited. So following that meeting by the MRC, we had decided to provide PrEP on-site at the South African sites. So PrEP use was voluntary. So when participants came in for their visits, they were counseled on what PrEP is, how it works, and then they were asked if they wanted to start PrEP. So it was optional. So women could decide if they wanted to, if they did not want to. Practically, because I was a site clinician and I did see participants, so we found many women liked the idea of PrEP for those that started PrEP. It was something that they could initiate on their own. Their partners didn't have to know about it. It gave them a sense of empowerment. So many women were very enthusiastic and excited about the prospect of PrEP. Other women just felt PrEP didn't work for them. Some of them said, I know I'm not going to take a pill every day, so I don't want to start it. Some women felt they were not at risk. You know, they had one regular partner. Some women felt that they were using condoms all the time. So women, you know, were given a choice to start PrEP and were empowered on PrEP and what it is. So they could decide to start or not to start PrEP. But overall, specific data on PrEP use was not captured as part of the ECHO study because it was offered as standard of care. What we did capture, though, was start and stop dates of PrEP use, so we could comment on that. Interesting finding, though, was in women that did start PrEP, we found that 2/3 of these women continued PrEP at study exit, you know, which was quite nice to find. Yeah, thank you.
Okay, thanks, Ivana. And maybe Thesla, over to you for the last question.
Thank you. So I think it's less about failing young women, but more around we're dealing with a very fragmented healthcare system, specifically in my country. And there've been so many talks about integration of care, but you talk about integration of care in the context of having an overburdened healthcare system. So when we look at how do we go forward, it would be important to ensure that there's operational efficiencies built in to all of our systems, that the providers are given enough support to make sure they can implement this grand idea that we have, because it does rely on a lot of effort to be put in. I do think in terms of comprehensive care for young women, if we're not dealing with male partners, it is a challenge. And as much as we had open door policies at every single clinical trial site for testing and treatment and notification of partners for STI treatment, there's a breakdown in our social system where there isn't that open communication. So a lot of our efforts currently are also looking at intimate partner violence, communication, empowering young women to openly discuss these issues with young men that they're in partnerships with. I do feel that we need to go back to the drawing board and start to educate young boys, children in schools, so that we can see a change in their mindset, so that they respect women and respect their own sexual reproductive health, or we're going to have this issue that just persists for many, many years.
Great. Thank you very much to the speakers, and thank you all very much for joining us.
Thank you.